World. Welcome to our first Change 2021 online event. Could I please ask everyone to mute their mic and to close their videos so that we have no disturbance from the background noise, and also we can ensure best possible streaming quality for this event. Today's event is being recorded and it will be shared on our YouTube channel following this event. My name is Sameer Deshpande. I'm the Associate Professor and the Managing Director of Social Marketing at Griffith. And so we welcome you all on behalf of the entire Social Marketing at Griffith team and the co-chairs of Change 2020. I will moderate today's session. We had hopes that 2020 may be different than the 2021 event is different from 2020 in terms of running it face-to-face, as we are all craving for good human interaction in person. However, we're still not ready to have all of us in the same room physically, and so we decided to go online, at least for this year. So today's event is one of the three main events that we are scheduled to organize online. But before we go any further, we want to acknowledge the traditional custodians of the land we are meeting on, especially the Turrbal people who are the residents of Brisbane City. We want to pay our respects to all elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander people. Our team has worked hard to curate this event. So I will first thank all our team members listed on the slide, including our speakers. The Change Conference is a brainchild of our center, Social Marketing at Griffith. We are the world's largest university-based social marketing center. This event, Change 2021, is for change makers and celebrates people and leaders that take a stance and make change happen. Our mission is to help more people empower, enable, and enact change that improves their lives and the lives in the communities and benefits the planet. We are excited to kick off the first event today. For this event, we decided to focus on the topic of encouraging COVID vaccination uptake, as we hear news from all corners of our society on certain sections being hesitant to the COVID vaccination. As this graphic shows, a lot of countries are aggressively vaccinating their residents with one of the many vaccines available in their respective countries. Some countries like Israel have done exceedingly well, while others, including Australia, are lagging behind. We know from the authorities that 70 to 85% of the society needs to be vaccinated twice to reach the herd immunity, so that we can then at least have the resemblance of going back to what was the pre-COVID normal. However, no country has reached that status, although Israel is nearing that goal. When we consider the residents' acceptance of COVID vaccination, it varies across countries. It is lower in China at 11%, as we learned from Think with Google, their US division. But it varies. It is 25% in the US, it's 32% in Germany and Singapore, and a whopping 45% in Russia. Overall, the hesitancy rates are consistently high in most countries. Needless to say, these rates vary by a variety of demographic and psychographic factors, such as age, income, education, ethnicity, and religious beliefs. For example, just this morning, I heard that on ABC that Australians above 50 years are showing hesitancy towards AstraZeneca because that's the one that is going to be administered with that demographic. So it's an evolving situation. And so we felt that we should highlight the importance of it and ways to address it. So what's the particular scenario about vaccine hesitancy or vaccine acceptance in Australia? Between October last year and February this year, the Gold Coast Public Health Unit ran a survey asking people who visited fever clinics at the Gold Coast University Hospital and Robina Health Precinct if they intended to get the COVID-19 vaccine. From the 27 and 2706 responses, we learned that over 50% of respondents definitely intended to receive the COVID-19 vaccine. Around 15% said they probably would or definitely wouldn't receive the vaccine. Similarly, a study conducted by researchers at the Australian National University showed 1 in 5, which is 21%, respondents would probably not or definitely not receive a vaccine. To get an Australian perspective or Australia-wide picture, one of our Griffith researchers, Professor Bella Stantic, analyzed big data from Twitter, which includes more than 97,000 Twitter posts from 42,000 accounts. He tried to track Australians' perceptions to COVID vaccination hesitancy, and he witnessed dramatic shifts from 90% to high 40s over a 2-month period in early 2021. The perceptions vary widely depending on the events that take place the previous day or that week. In other words, Australians, like the rest of the world, are not clear and stable in their views towards COVID vaccination. So the medical, public health and the government sector needs to employ strategies to address vaccine hesitancy among Australians, as we all know that vaccines will build immunity at the societal level and help open up the economy and hopefully restore our new normal way of life. Me and my colleagues had proposed a 10-step guideline for behavior change managers to address vaccine hesitancy. In today's presentation, 3 speakers, including myself, will touch upon various issues more or less related to these 10 steps. Off the bat, we want to confess that promotion is just one of the many strategies that need to be implemented to reach that minimum 70% mark of the herd immunity level. In other words, our discussion in this webinar will not cover all the necessary approaches on the topic, and this is purely due to time limitation. And so we accept the limitation and we apologize about that in advance. As we know, vaccine hesitancy is not new, and opposition to COVID vaccine is just an addition to a long line of opposition to other kinds of vaccines. For example, smallpox vaccines similarly faced such opposition that was addressed with several strategies, including messages such as those that you see on this slide. So with that short introduction to our topic, let us now jump to our first presentation. Before I introduce our first speaker, Associate Professor Holly Seale, I wanted to share the format for the rest of our session. Each speaker has been allocated a certain time limit, which we will try to follow. We would like them to present their thoughts uninterrupted. However, all of you audience members are encouraged to ask questions in the chat room. Our strategy director, Dr. Julia Carins, will be monitoring your questions. And eventually, after the presentation is completed, she will curate those questions and moderate between the speaker and the queries that you may post in the chat room.
To date. To get us started, I wanted to kind of actually think back a bit in this pandemic. We've now made it to 16 months since that kind of initial early cases of COVID emerging. And so, this goes actually back to 2019, back in December, even though really kind of, I suppose, on community radars, it wasn't really until February, March, that things really started to ramp up. But, you know, think about, you know, how, you know, what's happened over that time. You know, think about, you know, the public health strategies and the public health language that has now emerged into all of our vocabs. And, you know, take yourselves back even a year to think, you know, were you ever talking about quarantine? Were you talking about isolation? Were you talking about social distancing? Where, you know, had you ever had a conversation about what type of masks you should be wearing? You know, we've actually gone through as a community quite a transformation over this time already. You know, and with that transformation, we've actually seen community coming with us in a way that maybe we haven't experienced for a long time because of an infectious disease event. People adopted the need to you know, to distance themselves from each other. They washed their hands. You know, when we went into the supermarket, we were conscious of touching different surfaces, you know, and then, you know, across Australia at some point or other, we have all had the time of needing to wear a mask, whether it be when we're out and about or on public transport. You know, this has all become part of our, you know, of our repertoire. You know, these behaviors and these strategies, you know, really, they were quite unfamiliar to many people. Yes, you know, the use of quarantine and the use of isolation, they are not new. You know, we have, you know, had these strategies, you know, even back to the Dark Ages, you know, with plagues, people have been thinking and applying quarantine because of infectious diseases. But, you know, here in Australia, you know, really, we haven't had a lot of use of masks outside the clinical space. And so, you know, we've had to adapt, we've had to adopt, we've had to kind of, you know, go through the processes of thinking about it and you know, agreeing that, yes, it's the best thing to do to try and reduce the spread within our communities. Next slide. And so I'll go to the next slide again, please. And so time has passed. You know, these strategies have been applied, you know, with ebbs and flows, certainly here in Australia, that, you know, we have been quite disparate in the different states and territories and what they've had to do. And that's fine. You know, that's been appropriate because of the way that we've had community spread over time. But we are now entered a phase where, you know, I suppose we are moving into an area where we should be more familiar with. And that is the introduction of a vaccine into our public health strategy. You know, we rely on immunization for a range of other infectious diseases. And you know, we've been delivering vaccines for over 200 years to some level. You know, if you think back into history, and actually even before that, if you're really a history buff and want to know more about immunization, we go well back, and that's quite interesting to read that history, especially because this week is World Immunization Week, and so, you know, worth a chance to kind of reflect back on you know, how we have changed in immunization programs and policies and practices over time. But where are we at right now? Come April 2021, we have a COVID vaccine program that we are trying to roll out. Next slide. And we have now all been exposed to this different language about Australia's vaccine program and about the different phases. This has started to again come into our vocab about kind of thinking about your own eligibility, maybe the eligibility of family members and friends, and also starting to think about the different vaccine candidates, of course, products that make up part of our package here in Australia, but also, I suppose, the packages that are being rolled out internationally too. We've got a lot of this jargon happening around us about the different vaccines. Next slide. But just because a vaccine is available and it's free and it's, you know, hopefully going to be made more accessible, but that's a story I'll get to in a second, it doesn't necessarily mean that people will receive it. And the problem there is that our vaccine programs are only as successful if people receive them. Having a vaccine doesn't equate to having reductions in morbidity, mortality, and potentially transmission because it's just available. We have to get it into people's arms. This slide represents some data that came off an opinion poll done by ABC News. I know Sameer just spoke about the results from another opinion poll that's been published today in The Guardian, showing variation in acceptability of these different vaccines. I did some of this work last year, you know, and we did surveys, you know, back all the way back to kind of April, May last year to kind of see, well, if a vaccine did become available, how, you know, how many people would receive it. These surveys have continued to happen, you know, in some degree over time, and we have seen shifts in the perceptions of people around whether or not they are very, very likely, somewhat likely, or maybe not so likely, or maybe refusing to receive a vaccine. And it changes. You know, the data, you know, even right now, if you look at the different surveys that are publicly available, you will see variations in the data available. And some of that definitely we need to reflect on: how was the study done? Who was the population surveyed? You know, do they reflect the population of Australia in terms of age, gender, ethnicity? You know, that's, you know, we don't always know that. And so it's important to, you know, kind of take some of these findings with a little bit of a caveat that, you know, even by changing the wording of the question, it may also have an impact on what people think and how they answer the question. But it's all we've got to go for right now. And it's important because we need to track what's changing. So as you can see here on this slide, we have got a spectrum of vaccine acceptance around COVID. And this compares what was found during 2020 compared to what we're at for February 2021, so earlier in the year. Next slide, please. And from all of these studies that have been done to date, you know, really we do know that there are particular pockets within the community that may feel not so willing to receive the vaccine. And these have again been publicly reported that, you know, there seems to be people who are, you know, in that kind of early to mid 20s to early 30s, people may be more likely to be female, speaking a language other than English at home, having maybe lower levels of education, living in more rural and remote areas, and people who find themselves in financial distress. These are some of the demographic and social characteristics that have now been associated with people saying that they are less willing to receive a vaccine. What is this based on? It can be based on their demographics, but what we also know of those demographics is that there are also variations then in how those demographics influence people's perceptions and their feelings around the safety, the efficacy, and their confidence in actually making decisions. So it's important to think about those demographic factors, but we need to also look beyond them. Next slide, please. Hearing that someone may have some sort of reluctance or variations in their beliefs about immunization is nothing new. You know, and I put it to the group who's listening online now and to those who listen to this presentation later, that we probably have all heard someone say one of these statements. I regularly review, survey and interview community members, but even healthcare professionals, and I've had them in the past say to me, oh, the flu vaccine gave me the flu, which we know is not true. And it's actually a misunderstanding about the vaccine and actually about the localized and, kind of systemic reactions you have after the vaccine, but it's not the flu. But it is these kind of languages that's emerged into people's vocabs about the reasons that they don't receive the flu vaccine. Some of this, of course, is also coming out with COVID. Next slide, please. And this all then comes under this umbrella of vaccine hesitancy, what people are talking about, in the media, in the mass media and other places, about why people are refusing or potentially just delaying their acceptance of a vaccine. So it comes on a spectrum. People can be very, very happy to receive a vaccine. They are the accept all, will get in there, get it done, no problems. They're not really the group we're talking about. What we're focusing on really is those kind of in that middle category where people may be willing to accept some, maybe delay other vaccines, or maybe just delay the whole thing until later, or have decided that vaccination isn't for them. And how this spectrum works changes over time. It changes with each of the different vaccines. It changes over population groups, over countries. And so we can't necessarily apply the same model into each setting, nor can we always draw back on what we know from other vaccines to influence what we know about COVID. Next slide, please. You might have to click through some of these. Thank you. And so what we know about the factors impacting on vaccine acceptance for COVID now, come under multiple different kind of umbrellas. But for what we're hearing a lot in the community is around that kind of confidence space, is about people feeling concerned about or having some hesitation because of wanting to know more or having some reservations around the safety of the vaccine, about maybe about how the vaccines were developed themselves, and wanting to know more about their particular health situation and about whether or not it's appropriate for them to get vaccinated. Beyond that, of course, what we also know about vaccine acceptance, it can be influenced by risk perception. So this is risk perception around whether or not someone feels that they have a personal risk for COVID, whether or not it's in their community. And so this is where people are saying, well, I'm not seeing any community transmission. People are getting on with their life. What's the value add of the vaccine here? But we also need to be conscious that there is another element here in play, and that's convenience. And so it is about the capacity to go and get a vaccine. Now, I already mentioned COVID vaccination is free, but that doesn't necessarily mean that there aren't other convenience elements at play. Next slide, please. And this is when I want to bring in this other model of vaccine acceptance. And so this is called the 5 A's. It was put together by a colleague based in Europe. And it really then tries to tease out those additional elements impacting on acceptance, those of awareness, affordability, and access. And so, being aware doesn't just necessarily mean that you are aware that a vaccine is available, yes, no, but it's also being aware that you are eligible to receive a vaccine, or that you know how to book into the system, you know how to go to the clinic, you know how to go to one of these mass vaccine sites. And not everybody knows that. And so we can't make those assumptions that, everyone's level of awareness is the same. And it's the same goes with affordability. That's not about the cost of the vaccine, but it's about time costs, the capacity for somebody to take time out of their day to go and get that vaccine. If that time cost is too much, then they're going to maybe put their priorities on other things. Other life issues come up. Next slide, please. And so what the World Health Organization has tried to do, working on a model that was put together by colleagues, part of the Behavioural and Social Drivers Working Party, a couple of years ago, and reformed recently, that I had an opportunity to contribute to, was about trying to take all of these different elements and think about then, how do we design programs, vaccine programs, to actually talk to each of these different elements that may then reduce the burden or the barriers to getting vaccinated. And it's not just about the thinking and feeling elements, but it's also about social processes. So about the wider community, and how do we bring them along on the journey to try and influence or nudge people to go and get vaccinated. It's also thinking about those practical elements that I was just referring to. Next slide, please. And again, sorry, tap through, thank you. And so here is kind of what I suppose for me right now is some of those elements that we could be doing, drawing on that World Health Organization model to try and build vaccine confidence. Now, I've been asked to talk to the media, and I've been literally spoke to someone this morning about that recent data coming out in The Guardian. And what we really need to be careful here is that when we speak about vaccine confidence, are we talking about the individual vaccines, or are we talking about the program? So we might have high levels of confidence in the program, but variations between the different vaccine candidates. Now, that's something new to this kind of program, whereas in the past, people may not be so aware of the actual product name of the vaccine that they're getting. I got a flu vaccine. Great. What one was it? Good question. I didn't ask because it's the flu vaccine. We just normally get the product. And so, but here at the moment, we have community members actually using the product names in their discussions, and they know some sort of differences. They presume that there is differences between the different vaccines. And so, what we want to do is build confidence in the vaccines themselves, and that's where groups like Atagi come in, and the government messaging that is talking about the changes in the recommendations, and using data to make sure that they are up to date with all the safety and other elements that promote confidence in a program, but also about the individual vaccines. And so, what I'd be loving to see more is individual stories happening, getting champions and ambassadors out there to talk about the reasons that motivated them to go and get vaccinated. And that motivation is really important, because it may not be about someone's particular perceptions of risk, but it may be forward thinking. It may be about thinking about getting a vaccine because it allows me to go and see my family and friends who live abroad, who I haven't seen for over a year. And this is what we need to start doing, is tailoring some of these conversations. In the last minute, I've just been given the warning. I've just switched to my next slide. What we've got to be careful here, and I think the warning came out from the Australian Medical Association and other groups earlier in the week, is that there is a lot of dialogue happening at the moment about these different vaccines in the mass media, in our dining room conversations amongst work colleagues. But how much of the information you're hearing is actually true? There's a lot of what people are calling misinformation or disinformation. Next slide, please. And what we need to really be careful of is that, the information that we're passing on or giving oxygen to, is that the most appropriate information? We know conspiracy theories can increase or flourish at times of uncertainty. And so what we really need to do is make sure that we are filling those gaps and addressing that with the facts coming through, and actually having credible information to try and damper down any issues. Now, this could be a whole presentation in itself, and I acknowledge I have not got the time, and I'm sorry about that now. But what I want to leave you with is a couple of resources. First one is of course the WHO package, and so they have been doing a lot of work to try and put together toolkits for different groups in the community, government stakeholders, to try and help people to navigate the infodemic. UNICEF has also released a toolkit, and it's worth having a look at the both and making sure that they talk to your needs. Beyond those toolkits, at a community level, there are now games coming out to try and what we call kind of inoculate people against misinformation. And if you are someone who has a position where you interact with maybe younger people in the community, a game like this might be really useful to have a go. But hey, look, I had a go and I really enjoyed it. Next slide, please. We know that in presenting information and making sure that factual information gets out there, we know that during times of heightened risk or situations like outbreaks and pandemics, and even just generally about immunization, that our medically trained people play a key role then in disseminating that information. But the challenge is, and what I've been hearing, of course, is that people aren't necessarily turning up to their clinic visits. And so we also need to equip other people in the community to make sure that information gets out. How we can do that is that we can really kind of make sure that we are getting some powerful voices out there. And these videos are really great examples of communities of practice, whether they be in clinical settings or community more generally, trying to come out and get their voice across about these vaccines. So again, can't show these videos now, but if you have a moment, do search them out and have a look at kind of, how are they approaching the message, what kind of information is being said, and about, kind of how does it make you feel in terms of promoting, communicating, and trying to engage your community that you are trying to influence around this. So thank you for that whirlwind of social science and immunization. I appreciate the chance, and I know there's been some questions popping up in the chat room that I will have a go of addressing.
Thanks, Holly, a lot for sharing your thoughts. If I could pick on a couple of thoughts that stuck with me, one was I really like that spectrum of hesitancy. Let's not assume that everyone has one kind, cookie cutter kind of hesitancy. People vary by where the hesitancy is sourced from, what are their reasons, what's the lived experience that causes them to ask questions. And an important point is these are important questions. They have to be respected. One needs to have an important conversation about this. And then I like that 5 A's model of vaccination, where there's no one solution. You need multiple strategies that we need to bring to bear when we look at how we can convince wider Australians or people in society to accept it. So let's now jump to questions, because Holly, unfortunately, is going to be pulled away for some other important meetings about vaccination. So we thought that we're going to break our agenda a bit, and until we have the honor to have Holly with us, we would like to ask her questions. So I'm going to now ask our strategy director, Julia Carins, to take over and moderate any questions that have popped up until now for Holly.
Thank you, Sameer, and thank you very much, Holly. I've got a couple of related questions here for you about not necessarily vaccine hesitancy, but, sorry, I'll just show my face. People may not necessarily be anti-vax, but more vaccine hesitant, and particularly between the different types of vaccines. Some of them had concerns about the safety in the process, and now their concerns are highlighted through some of the issues that have come up with the AstraZeneca vaccine. So what would your messages be to them, and how can they find ways to access the vaccines that are suitable to them?
Yeah, that's really. Have I got an echo? Sorry, that's better now. Really good questions, and here it's all about tailoring. We've seen a lot of the mass media resources going out, and I think that was a good starting platform, and we needed to get those messages out to align with the release of the campaign. But I think at this point we do acknowledge that different population groups do need those nuanced messages to come out now, and it may be more about safety, it may be about appropriateness of vaccine for different risk groups and the rationale, but it may also be about trying to pull up those motivating points. And so just was having a conversation with a colleague earlier that when we think about motivation and trying to, I suppose, pull on that idea of risk, we've literally had WA go through a snap lockdown for 3 days. And so, how do we try and, maybe do we need to bring that into our conversations, that, we are trying to forward plan with a vaccine to try and reduce those kind of elements, in the future. I already said about the motivation around travel, for the populations that I've been doing my research on, and that includes culturally and linguistically diverse communities, there's a lot of desire to go back abroad, and to travel and go and see friends and relatives. And so, for them, the vaccine is about opening borders, but for others it may be about their own particular health condition and keeping and reducing the risk for adverse morbidity because of COVID, and that's still a potential concern, because we know that we've been very lucky. But, we are in a situation where we've got these variants emerging worldwide. We've got, countries that are, seemingly doing well, that have now looked like they are, on the back foot of things again, unfortunately. And so, things during pandemics can happen very quickly and change. And so this is maybe what we need to bring into our understanding about why we get vaccinated.
Thanks, Holly. Just one more question. You spoke about the differences in vaccine hesitancy between previous vaccines and this COVID one in particular. How do you deal with the hesitancy that comes from broader issues like faith in the public health system and the distribution in various parts of the country and all of those things, in particular with this COVID vaccine?
Yeah, and that's that's acknowledging that messaging and communication and these kind of more social science drivers of change, they need to work in alignment and complement then changes happening in the system processes. And we've already seen that change happen in the last fortnight, about the kind of the shift within states and territories to start thinking about these mass vaccine clinics. And I think that really reflects on the fact that, there was community pressure to say, people going to GPs is just not going to work for everybody. We need to think about how do we change up our approach to try and make sure people, it's accessible as possible. And so, that's about, thinking across the system of immunization. And, there's a lot of talk about the actual delivery mechanism, but I think also the focus needs to be around the booking mechanism that, I know I tested out, a month or so ago and found it, complex and needing multiple changes and inputs and all the rest of it, and English is my first language. English has always been my first, it's always been my first language of my family. I come from a different space. And so, I acknowledge that, for other members of the community, that booking system is a nightmare. And so, how do we think about that whole process of trying to get an immunization and try and make it as user-friendly as possible?
Excellent. Any more questions for Holly? All right, I think more might pop in as we go along, but I'm also cognizant of time. So I will let us now move to our next speaker. Thanks, Holly. So Doug Hendrie, the floor is yours once I introduce you. Doug is a Melbourne-based writer and has featured in the ABC, Sydney Morning Herald, and Australian. Formerly, Doug served as the associate editor of News GP, which is the mouthpiece of the Royal Australian College of General Practitioners. So his focus on this presentation will be more on the role of media, mass media, in addressing the whole issue of COVID vaccination. So Doug, over to you. Thank you.
Thanks, Sameer, and thanks for the opportunity. And it was also great to hear from Professor Seale. So, as mentioned, yeah, I'll be focusing on the media aspect, given that's my kind of background. For much of last year, I was focused on, firstly, the COVID pandemic as it sort of emerged and kind of shocked the world, and then the kind of the mad rush and the record-breaking rush to get to a vaccine. It still boggles the mind to think that the previous record for a vaccine, I think, was 4 years, and this time we did it in under 1. So it's pretty remarkable we're in this position. But as Holly pointed out, that does still leave us with the position of hesitancy. So just very briefly, and much of this would have been covered by Holly's presentation, but the current state of play. So COVID vaccine hesitancy has increased substantially from August last year, which of course was around the time of Melbourne going into its long-lasting second lockdown. It's increased, I guess, as perhaps we've come out of that period of lockdowns and as Australia's entered this kind of bubble state, insulated from the rest of the world. So the crucial number for me, I thought, was in January, 21% said that they would probably or definitely not get a safe and effective COVID vaccine, up from 12.7. And so that obviously begs the question of, well, where did that increase come from? And you'd have to suspect that a lot of us come about the focus on vaccine side effects. So the latest news about the very rare blood clots linked to AstraZeneca is obviously having real world consequences, with GPs reporting bookings substantially down. So if we think about the overall goal, which is to achieve herd immunity or as close to as possible, while informing people fairly of benefits and risks, and without engendering unnecessary fear, I thought I'd take the opportunity to basically give a quick snapshot as to where I thought we were at. Next slide, please. Obviously, no vaccine is 100% safe, and there are always going to be side effects, and some rarer side effects can be dangerous. We kind of tacitly accept the vaccines that we are given in childhood, and also when we go to travel overseas, when that's possible again. But the COVID vaccines are obviously under a huge amount of scrutiny. There's a lot of, there was a race to be first, there's a race to prove that they were safe and effective. And of course, clinical trials, by their nature, they might have many thousands of people, but they're not millions of people. And that's what we're seeing now as these vaccines are rolled out around the world. Some of the rarer side effects are emerging that weren't seen in clinical trials, just as a function of the sheer numbers. So media reporting in this vault can actually, if not done carefully, inflame the issue. How so? By basically sustained focus on the negatives. So not necessarily a single article alone won't do it, but a sustained campaign across a number of outlets can certainly serve to drive down vaccine numbers. And especially if it circles around fear and uncertainty and safety concerns, which, as Holly pointed out, are key drivers of hesitancy. So where are we at? Well, in Australia, around the world, are we seeing helpful, rational mass media analysis of relative benefits? I would argue that broadly, yes. I think they've done a broadly good job, especially in the kind of public-minded press and broadcasting. But there is, of course, media have their own pressures within different outlets. The rush to publication, the need to be first, and also there is an amazing thirst for information about where the vaccine rollout's up to. That has seen missteps even by major media outlets. So, for instance, the news that AstraZeneca had limited efficacy against the variant that had first emerged in South Africa, which came out late last year, that was framed as a blow against the overall efficacy of that vaccine in major outlets, up to and including the New York Times. But the key fact that severe disease was still averted was tucked away further down the page. And my question would be, could that have been done perhaps better, given that most readers scan the headline photo and the first few lines before moving on? We're all adept at this kind of a skimming technique, especially as we read online. So for something as important as that, my question would be, would it not be worth elevating something like that to ensure that more people would see it? Something interesting I've found in my kind of observations of how the media has reported the vaccine push is that the tabloid press, which obviously tends towards a more emotive style of reporting, has been broadly favourable to the vaccine push, and has in fact used that kind of emotive techniques to kind of target vaccine skeptics, such as the former celebrity chef Pete Evans. And I'll give you an example of where the tabloid press has actually done reasonably well on the next slide. So the Daily Mail is one of the world's most famous, or sometimes notorious, tabloid outlets. But the way in which they tackled the death of the woman who died after taking the AstraZeneca vaccine was, I thought, actually the tabloid articles relatively considered. So they've taken an emotive response. They've given the details about the woman who died days after the AstraZeneca, talking about the gaping void her death leaves in their lives. But the actual detail about the vaccine is still relatively free from emotive language, and puts it into context of the overall rollout and the shift in focus that then subsequently happened at a federal level. So I've actually been pleasantly surprised broadly by how the tabloids have handled the vaccines. I mean, they could have, some of the less responsible could have gone for sort of vaccine fear and shock and awe, I guess. But I think given the sheer magnitude of the pandemic, they probably made a calculated decision that was going to be a dumb move. And in one of my previous roles, I have been a media lecturer, so I won't overly bog you down in theory, but I just think it's interesting to note that the way in which we used to conceptualize media, it started off thinking it was like a hypodermic needle, and that a message would be injected into us and would be kind of taken up without kind of critical thought. It had a huge amount of influence. That, of course, is not accepted anymore. And the idea of media brainwashing is no longer accepted at all. Newer theories suggest a more nuanced role, and that media influence is fluid and contextual, and it can be more influential at certain times, such as when there's a large demand for information, or when new events need to be made sense of, or when we're uncertain about what to do or think. And obviously, media can play a crucial role, as I mentioned earlier, in setting the agenda. So by giving us the things to sort of think about and talk about, they play a really vital role in that, in terms of creating public dialogue on an ongoing basis. And repetition, as I mentioned before, is also a key technique in terms of boosting kind of influence. And we see that particularly during political campaigns, the use of repetition. So COVID ticks many of these boxes. Here we have a major new threat leading to an upheaval of our established way of life. Many new public health measures, such as lockdowns, that do come with costs as well as benefits, and the new vaccines that have passed clinical trials, but we're now seeing the rarer negative events, and they all have to be weighed up as well. And you throw that into the mix alongside the ongoing rise and emergence of social media as kind of a key way in which we process information, make sense of it in a social setting, and so on. It's particularly in the pandemic, has played a really outsized role. That's not only in sort of sharing and debating mass media stories amongst our friends or acquaintances, but also provides that support network to inform your choices. So anti-vaxxers, for instance, would be more likely to surround themselves with other people with similar views. It's just human nature. We gravitate to people who are like us. And so then you can have that kind of echo chamber effect that takes place in social media. Of course, and as Holly mentioned, accompanying pandemic has been the infodemic, where misinformation has just flooded the world. and has led to some really sad real-world consequences, such as, for instance, Brazil's reliance on unproven drugs such as hydroxychloroquine and so on, because they were pumped up at the time and sort of hailed as a cure. And of course, they have proven not to be the case. And so social media sadly does an amazing job of spreading misinformation because it's so easy to spread information and information that people want, regardless of whether or not it's true. It spreads much more easily on traditional media, which for all its flaws does rely on gatekeepers, editors and so on to weed out dangerous mistruths. The incentive there, of course, is to avoid defamation and lawsuits and so on, but also as a duty to the reader or to the viewer. Social media has until recently not been regulated in any way the same way. So it's been to some degree open slather, and it's only in the recent year or two that we're starting to see some welcome change there. Next slide, thanks. Holly touched on this, but I thought it's worth to pause and have a bit of a deeper look at what is it that people do when they are assessing or deciding whether or not to take a particular vaccine for COVID. For instance, if you look simply at the chance of acquiring the new blood clotting disorder, it seems to be about 4 per million. The mortality rate amongst those might be 1. So you might have 1 death per million vaccinations. And as I note there, the US has actually only had 6 cases amongst the 7 million people with the AstraZeneca. 1 death so far in Australia has been linked to the vaccine, to my knowledge. But the way in which we assess risk, we kind of inflate these things, especially when we absorb them in a kind of mediatized environment. You might think, oh, AstraZeneca, you make an association, oh, that's the one with the blood clots, therefore I will avoid that. So there's a mix, I think, of a rational assessment because AstraZeneca isn't the only option. There are others. And so I suspect that many Australians who might be described as vaccine hesitant are in fact acting quite rationally. They still want protection against COVID, but we're in the very lucky position not to have had major outbreaks, as we're seeing in India and Brazil. So there's less urgency, which means that people might be prepared to take more time to achieve immunity. And so they may well wait for Pfizer or Moderna or other vaccines that to date have not shown these kind of side effects. But this calculus would be very different in other nations. So as I mentioned, India and Brazil, to a lesser degree now, the US, where the very real risk from COVID and the new variants, which unfortunately threaten immune escape in some points, would definitely be deemed to outweigh the risk. So many would take that smaller risk to be able to return to normality. And I see just in the last couple of days, the US is, I think, about to donate millions of doses of AstraZeneca to stricken India because the very small risk of a blood clot has to be weighed against the fact that you know, the hospitals are out of oxygen, and that if you get the severe form of the disease, it's all but game over. Positively, the vaccines seem broadly capable of providing protection against severe disease, even from the variants to date. So it doesn't necessarily matter which vaccine you get, as long as you get one. So that brings us back to vaccine hesitancy. Is it hesitancy, or is it simply people are acting relatively rationally? There's obviously an element of fear and concern there, but we're avoiding specific risks in favour of an alternative perceived as lower risk. Next slide, thanks. Holly touched on this, but I just wanted to go into a little bit more detail about the origins of the modern anti-vaxxer movement. It began in the late 90s with a now withdrawn paper by Andrew Wakefield, who was removed from the medical register, who erroneously linked vaccines and autism. And it's since emerged into a specific group of hardline skeptics who have been very good at using social media to have disproportionate influence. But as Holly has pointed out, there's very limited overlap with a much larger group who may be hesitant about vaccines. It's been estimated in research I've seen that about 12 prominent anti-vaxxers are responsible for about 2/3 of all anti-vaxxer content that circulates on platforms like Facebook or Twitter. Vaccine expert Dr. Harper has pointed out that the sheer repetition of negative stories about COVID vaccines may have an unfortunate effect in increasing the ranks of the hesitant. And he puts out, if you keep telling negative stories, people become far more reluctant. And they might become anti-vaxxers, but they'll express it by not rushing out. Epidemiologist Hassan Valley has put it, people are uncertain and cautious. They don't necessarily know a lot about this, this new vaccine. They're worried about what the right thing is to do. And so we have to give them as much good information, reliable, fact-based information to make the best decision for themselves so that they can feel they're making an informed decision, which obviously takes time. Next slide, thanks. And just a very brief case study here on the impact of the no jab, no pay legislation. This was laws introduced federally in 2016, which basically placed additional cost on not having children fully vaccinated. So you would miss out on certain tax benefits by refusing to do that. States have some overlapping legislation, no jab, no play, which actually does not allow children without complete vaccines coverage from actually accessing childcare and so on. Did it affect hardliners? The research suggests it did not. Many vaccine refusers are likely to be higher income who would not be affected as greatly by tax breaks or subsidised childcare. But it certainly did lead to higher rates of catch-up vaccinations amongst lower income households who would obviously be more likely to be affected by the inability to access these benefits. Professor Julie Leask, who I interviewed at length last year, has told The Guardian that the policy actually served as a prompt for people who are already happy to vaccinate their children, but had very little effect on those who are active rejectors of it. And Professor Leask and others have subsequently argued in the Medical Journal of Australia that actually targeting vaccine refusal does not offer greatest benefit for better coverage. She argues, or she and her co-authors argue, it's the least important of the three factors: refusal, hesitancy, and barrier to access, which is why I think that Holly focused so much on those factors in her talk. Focusing on hardliners is, it's like arguing with conspiracy theories of any guise, I guess. It's difficult and potentially pointless. Next slide, thanks. And further on that, do we actually need to worry that much about holdout groups? If we're aiming for herd immunity, so say 70, 80, maybe 90%, we have to assume that there are a certain number of people who will never get the desired vaccine. That might be anti-vaccine views, but it also might be for convenience or complacency, or you simply might never get down to the GP or to the big centres. The good news is that herd immunity or herd coverage can still be acquired for most diseases, even without this group. Although the recent gains made by measles, which is far more infectious than COVID, suggests we're very lucky that COVID isn't similarly inclined. To my mind, the resurgence of measles was very much a pre-COVID wake-up call. We saw that rebounding quite strongly, and there were some strong correlations drawn to the growing power of anti-vaccine networks in countries like Japan, where there's very low rates of vaccine acceptance, as well as some other parts of the world. To my mind, this information suggests it's much better to direct clear, accurate information and reassurance at the middle ground who are uncertain, rather than those who have already made up their mind and have determined not to do it. The group in the middle are obviously those more likely to seek reassurance or ask specific questions of accessible experts, such as GPs. And in my previous role, working for the GP College, that was a big focus for them because once someone's in the GP clinic, they can ask whatever questions they want, and the GP can kind of run them through the detail, the pros and the cons, the risks and the benefits, and so on. And next slide, thanks. And this is a piece I covered in depth in 2019, which was about the tragic case of measles in Samoa, where there was an infamous local tragedy in which 2 nurses wrongly administered a muscle relaxant and caused 2 deaths. This error was unfortunately picked up and amplified by local and international anti-vaccine advocates. And as a result, vaccination rates plummeted, and so herd immunity was lost. In 2019, measles took advantage of this and spread widely. About 5% of the whole population got the virus before it was finally stopped, and 83 people died. The majority of these were small children. But the response I actually found quite heartening, because international teams raced to the scene, the government picked up the pace and addressed the issue head on, and they managed to achieve herd immunity still by the end of 2019. And so subsequently no further Samoan children have died from measles, which to me I think is a heartening story, because people can be anti-vaccine in a vacuum, but it takes, when you're up against a pandemic or something which is having really negative real world consequences on you or people that you know, it becomes a very different calculation. And next slide, thanks. So how then should the media proceed? Well, there's a lot to be said for simply honestly reporting as much context as possible. So things don't happen in a vacuum. There's been lots of water under the bridge. Place it into context, this new development. So a vaccine's got a new side effect, sure, but does it still cover severe disease and so on? It's also really important for the media, I think, not to downplay legitimate concerns because, you know, there are, as I mentioned, there are no 100% safe vaccines. There is always some level of risk, you know, however minor. But another interesting point here is that, as Claire Wardle of the Misinformation Debunking Organisation points out, the more that you say something is not true, regardless of how outrageous, the more oxygen you give it. And there's that quirk of human psychology, which means that repetition of information makes it seem truer, regardless of how bunkum it is. So there are real questions there, I think, over the validity of constantly debunking the wilder theories. Better, Ms. Wardle would argue, to simply ignore it and move on to more substantive topics. And next one. So in sum, what can the media do, both social and mass, to encourage considered uptake of the vaccines? For social media, well, as I mentioned earlier on, it's welcome that major social media sites like Facebook have been putting money finally into fact-checking and verification. They've started to put those barriers to sort of the ease of spread of misinformation, such as saying we're going to put these banners alongside the dodgy article you're posting, which basically puts the fact check next to the dodgy article and so on. So that should hopefully slow the spread of misinformation, but not stop it. And it does, to some degree, shift Facebook into something closer to a traditional publisher. I think the social media goal should be to further increase that. And something else that I haven't seen done that much yet, but would obviously be a huge benefit, is to actually reduce the reach of prominent and well-known spreaders of vaccine misinformation. You don't have to take down pages, you just have to make it harder for them to spread to mass audiences of millions of people. So it's not censorship, it's just removing the ability to spread like a virus. For mass media and traditional journalists, I think the goal should be to tell the ongoing story of the vaccine rollout as clearly as possible, making sure that legitimate open questions over side effects, efficacy, and uptake are covered, while ensuring that context is provided at all times. So informing without inflaming. And as I mentioned earlier, I've been pleasantly surprised by how responsibly most of the media has handled the vaccine push. Other sort of methods of helping out might be including reference to vaccine targets, or also the positives waiting at the other end. And we also have the good news stories from countries like Israel that are getting closer to restoring normality simply through hitting that sort of magic number of herd immunity. So, and I think once more and more countries achieve that kind of level of safety, I think seeing that light at the end of the tunnel will be a strong incentive as well, because that is what we are craving. And I think that's it. So yeah, happy to take questions. I think after Sameer does his presentation.
Thanks a lot, Doug, for your sharing your thoughts. I think for me, you highlighted 3 points that I would like to kind of quickly point. One was the whole point of media influence is cumulative. No one article actually makes a difference. So your point on how Andrew Wakefield's research got amplified so rapidly among the anti-vaxxers. It was not that one article that made a difference. It was that massive support that he received, unfortunately, that made to the anti-vaccination movement. And so something that we need to be cognizant of. And one way is to balance it out with equally important research-based, evidence-based articles that put the facts in place. The second point was about this comparison between risk and reward, which varies from culture to culture, country to country. And I think policymakers and social change agents like ourselves should be aware of that. The hesitancy shown by Australians towards vaccination is not going to be similar to that experienced by someone in India or South Africa or Brazil, as you pointed out, because of this difference between risk and reward. And I really like your idea or your observation on the middle group, who are neither pro-vaccination nor anti-vaccination, but they're waiting for the right signals. And here I bring Holly's 5A model, where if you offer the right reward, the right convenience, so on and so forth, awareness, etc., we can tilt the social norm towards pro-vaccination when the middle group is supportive of the same. So Doug, we will take your questions after I share my quick thoughts on a different topic, and then we can open up the floor to ask questions to him, answer questions that people may have. So while Holly spoke about the various aspects of vaccination and the resistance or the hesitancy and how one can address it at a broader level, Doug spoke about the particular topic of the media, the journalists, the influencers in them, how they can make a difference. And I thought that I will take another angle to influencing this whole issue of hesitancy by focusing on micro-influencers. And so I would like to spend next 5 to 10 minutes discussing the same. So Google, especially Think with Google in the US division, recently put out this question on the influence of micro-influencers. The topic is not new. The role of influencers in communication and marketing has been extensively explored in consumer behavior research. And I can say with confidence that we know a few things on how, who, when, and where influencers can modify consumer behavior in commercial and social marketing. And we can definitely borrow some of that knowledge for the purposes of creating the right norm for vaccination. And so I'm going to touch upon a few and then maybe highlight a case study from India on how Indian government went about overcoming that hesitancy to make India polio-free. One of the most influential people in COVID context are the healthcare workers because they are trusted as experts. And as the quote on the slide rightly suggests, that they should be using platforms like YouTube to spread that message. But there are many other categories of influencers, including these individuals listed here. Among these, some carry popular and aspirational appeal, while there are those like family members, friends, and religious leaders whom we personally know, trust, and follow. Each influencer relates to a specific segment, appeals to a specific segment. As a result, to ensure effectiveness, the more influencers we bring to bear, the more successful our behavior change efforts are going to be. So for example, we have this example of the much loved Dolly Parton, who remixed her old song Jolene and brought it to the COVID context to make it popular, especially among those who are her fans. Another example is the famous English cricketer Moeen Ali, who has been communicating regularly with the South Asian community in the UK. I am personally in touch with my South Asian colleagues in the UK, and I'm told that there is an unusually high hesitancy among that community. So Moeen Ali's efforts are much appreciated. And the same community in Australia has also shown hesitancy, who have migrated from the same part of the world that I have. So I thought, why not quickly talk about some of the insights where countries like India, Pakistan have faced similar struggles that they have faced in a very different context of polio. So I wanted to just share what did that government do to overcome the polio battle, and then highlight how micro-influencers played a crucial role in influencing those behaviors, which I believe are relevant to the current situation, both not only in India, but also Australia, where these communities have come from that part of the world. So very quickly, India had been working on reducing polio infection right from its independence in 1940s. But it had reached a point in 1980s where a few segments still posed as a stubborn demographic. And they tended to be, as the slide shows, tended to be in the two states, the poorest states of India, which is Uttar Pradesh and Bihar, which I have highlighted in red, especially on those 83 districts of those two states. And it just happened to be that the communities that were posing the most resistance, the final two demographics, were the underserved, lower income Muslim communities, as well as the unreachable nomads and the people who migrate around the country all the time. So I wanted to explore in my case study, which I have published by now, what strategies did Government of India with all its partners take to go from a case where we had several cases until 1985 to 0 case in 2011, so much so that in 2014, WHO declared India to be polio free. So what led to that decline? I just wanted to highlight some of those strategies. I do want to make it very clear that based on my comments, I may come across that I'm zeroing in on Muslims. I don't intend to convey that they are a problem, that all Muslims are vaccine hesitant, or that only Muslims are hesitant. We know that this problem is much wider than that. So my intention is to highlight a relevant example that we can learn from so that we can also address the current situation. So the behavioral objective was to administer 2 drops of oral polio vaccine among children under the ages of 5. Each of those 2 communities posed different kinds of barriers. The underserved Muslim population felt that this OPV vaccine was against their religion, and that for administration of OPV would result in sterility and impotency among the children. So they were very concerned about it. And I'm talking about Indian context. Although I'm hearing and reading similar reasons in the current context among the Muslim individuals in India. The migrant and the nomadic groups were hard to reach. There was no access to formal healthcare, and they had a perception that this polio disease was a curse of God against which we can't do much. So we just have to face the fate. So how did the campaign managers go about addressing this problem? The backbone of the effort was a strong voluntary cadre of 6,000 mobilization network members that worked tirelessly to convince parents to immunize their children. They worked with the vaccination team to reach the population where they live, where they work, and where they congregate. The primary message of that whole entire campaign was to convince to the parents that vaccinating children was everyone's responsibility and it belonged to all citizens. They highlighted several benefits, which was important. They stayed away from this avoidance-based fear appeal strategies, and they formed key partnerships with established and important Muslim educational and religious institutions. Special interventions were focused on areas where the communities visited, and the messages were plastered at several locations across all those districts that I was talking about earlier. They also ran an ad campaign in Hindi language, which is the common language spoken in that part of India. They used entertainment educational approach to make it more convincing. They also organize on a regular basis 2 national immunization days around the immunization week that Holly spoke about. They also organized sub-national, local, regional days around immunization, 6 of them throughout the year. But the point I really want to highlight is that they brought to bear several micro-influencers, and I'm going to highlight each one of them. So the first and the most prominent one was to recruit the prominent Hindi or the Bollywood film star Amitabh Bachchan, who's also the UNICEF Goodwill Ambassador. That he became the face of the campaign. So his just 2 drops for good life became the tagline that spread the message of vaccination. And he was, of course, very prominent across all media, and Bill Gates appreciated his efforts throughout the campaign. Since cricket is a religion in India, the national cricket team, as well as the IPL, Indian Premier League members, they came together and took the message of bowl out polio to young Indians. I'm just showing you one representative picture here, but they were all over media during that period, especially trying to reach the young Indian male who's quite receptive to the cricketers' messages. Other than that, they also hired traditional healers who were in direct touch, especially in the rural side of those two states. And then lastly, one also noticed the participation of religious leaders, such as imams or the faith leaders among Muslims. They were very cooperative because they were convinced about the effectiveness of polio. They asked attendees during their Friday prayer meetings to vaccinate their children, their patrons. They held prayers for polio eradication at festivals and religious congregations. They made mosque announcement publicly so that people living around those mosque areas could get the message on a regular basis. They issued appeals or fatwas in support of the program, and they created special communication material in the form of calendars and greeting cards, which were distributed among the community members. Imams or the faith leaders are highly respected among Muslims, and it was a great cooperative effort from their side to support the program. As a result of all these efforts, and I have not touched upon every aspect of the campaign, the vaccination team administered more than 100 million doses during the 10-year period, multiple times among children. That actually resulted in, and it was a very targeted initiative, which eventually resulted in a dramatic decline in polio infections in India. And eventually, as I said, India became polio-free and has remained so even now. Some of these aspects can be easily brought to bear to other contexts among such immigrant communities if we have to address such hesitancy. So I would like to end my thoughts with that slide and then open up the floor now to questions, which I would like Julia to moderate.
Thank you, Sameer, and thank you, Doug, also for some very insightful comments. I'm going to start off, Doug, with a question to you. You started to discuss effective strategies for eliminating disinformation in the media. What do you think are the most effective strategies for reducing disinformation or misinformation?
Well, misinformation, I think, is primarily a social media phenomenon. I mean, you do get some. Yeah, well, that's not, yeah. Obviously, mass media can be gamed as well, and misinformation can penetrate there. But at the very least, it should be more visible and at least more concrete. Whereas misinformation can very easily spread and then disappear after its work is done. You know, so and there's sources keep coming out. So I think mainly the misinformation battle should be fought on the social media front, which unfortunately basically means putting pressure on the large private owners of the social media sites to do more. They have traditionally resisted tackling misinformation because that means that they would be casted publishers, which would then come as, which would obviously come with a considerable cost and also potentially legal issues. But I think the tide is turning there. Facebook has been forced to, I think because of a tide of negative press, has been forced to address the issue of misinformation. And it's not, I mean, it's not only COVID, you know, it's been linked to actual issues with sort of militias and sort of the ethnic cleansing in Myanmar and so on. Like it does have real world consequences when it goes unchecked. So I think it has finally got to the point where they've had to act. But in terms of what we can do to encourage that, I think it's purely about just maintaining pressure or sort of advocating for that wherever possible, because it is being shown to work. And they do have the tools to do it. You know, they can reduce the reach of prominent misinformation providers. They can deplatform them. They can take them off entirely, as I think was done. Wasn't that done this week to one of Australia's? Didn't Craig Kelly lose his Facebook page? Anyway, so it's entirely possible to do. And I think basically we just need to advocate that they do more wherever possible, as opposed to focusing on individual providers of misinformation. I think the platform itself has a great deal that could be done there.
Yep. So then you also spoke about informing and not alarming, but informing and presenting information fairly. that tends to be around the concerns and speaks to your points about hesitancy versus rationality. People are rationally dealing with concerns about particular parts of the vaccine or particular vaccines. So do you think that same balanced view can be used for the positive statistics, the positive outcomes? Is that being balanced and fairly reported in the same way? Can you make a positive soundbite headline worthy?
Yes, I certainly think there's certainly a role for a communication campaign in kind of framing the positives. I mean, people would love to be able to travel overseas. They would love to not have to worry about their older parents who are stuck in the UK or whatever it is. So there's a thirst there. And even though we are in a relative bubble, I think there are huge positives that we can accentuate. So even though we don't have COVID on our doorstep or kind of in our streets, sorry, we do have it on our doorstep. But not in our streets and not sort of causing genuine kind of panic. The framing of the positives, I think, is quite an effective way to encourage take up. And I think arguably a much nicer way to do it. I mean, you don't want to have the kind of, obviously we don't want to get it to that stage, But I mean, I think you can see like America's example is pretty amazing. They were at one stage vaccinating more than 1 million people a day, wasn't it? Or many more people than 1 million a day. And because they've seen the worst that the disease can do, most people in America would have lost someone that they know of. And so the appetite there was just huge. And so people were just, crowding to get their shot because it was safety, it was protection, it was a chance to re-establish a normal life outside the four walls of your home. So why wouldn't you? But in Australia, we're in a very different reality at the moment. So I think we have to adapt to that local setting here.
True. And I mean, we saw very quickly their daily case numbers embed their way into our, evening news or so on. And now that we're perhaps getting our double-digit days and so on, do you feel that there's room in the media dialogue for other statistics to find their way to the top, numbers of vaccinations per day or how far the rollout has progressed and so on? Is that going to get the same volume or airtime, do you feel?
You'd hope so. I mean, that would be another effective way to do it, So if we could see that there was occurrence rates, if there was 9 months to get into that a magic number, say it was 80%, then I think that would be encouraging and people would kind of do their bit. And I think last year certainly proved that we were all willing to sort of chip in and kind of do something or not do something, as the case may be, not socialize, not go to people's houses and so on. So we were prepared to do it to avoid a greater harm. So I certainly think, with the right kind of messaging, you can really tap into that kind of pro-social aspect to do it. And I think, the suggestion you make is a good one. Show us the targets, and maybe also contrast to countries around us. We love a bit of competition too. So if New Zealand's doing far better, or Papua New Guinea sort of managed to vaccinate, a large proportion of their population, then show us that. I think that'd be positive.
Okay, so I'll ask you a question, Sameer, to give Doug a bit of time to catch his breath. Some of their comments coming through in the chat box are about social norms and in relation to your comments about influencers. And I'd like to ask you, how do you think they are effective? And do you feel that we should be using social norms like close ones like a family and friends, or those trustworthy sources that both Doug and Holly talked about? Which are the avenues that you think are most effective, or are they all effective?
Yeah, so if we are to focus on family and friends as our group where social norms is very effective, as you know, family members come in all shapes and colors and sizes. They are the microcosm of what the society is. There are some who are really supportive, there are some who are resistant, and some who are questioning or uncertain. I think that's where we can bring to bear who is those elements, those members who are actually supportive. I'm going to guess that the younger people who are the school-going children tend to be, will be more supportive. I could be wrong here. In the case of what they're hearing in the media, and might put pressure on their parents or their grandparents, or the grandparents on the other hand might be a bit more concerned about how this whole COVID vaccination or COVID infection is rolling out, and they want their kids and their grandkids to be visiting them more regularly, and they might be more supportive. in either case, if we find that certain demographic of a family is more supportive, I think we should be using, as Doug pointed out, their help, and then use them as the drivers of support, so that they are able to communicate with the rest of the family members to create some social norms. Because right now they are the ones who are getting vaccinated. They are the ones who are exhibiting that they are not facing any side effects. And so the rest of the family can be supportive. At the end of the day, social norms is going to happen by behaviors, not just by opinions. And so people who are vaccinating themselves, for me at least, are going to come across as the real influencers rather than people who just use scientific knowledge to provide their opinion.
Yeah, I guess that comes back to those personal stories that Holly was talking about earlier. And in all fairness, the media can do a lot to, put a spotlight on some of those positive stories and those personal stories, and really give that, substance to individuals as they participate in this rollout. We've all seen some celebrities, rolling up their sleeve, getting the jab, some politicians and so on. Do you feel that there is an appetite in the media, Doug, for more representation of more diverse groups participating in the rollout, or is it just more opportunistic in terms of it's set up as a presser for the Prime Minister to be having his vaccination today, so that makes a media story?
Yeah, that might be a clever way to do it in terms of focusing on groups that may be less certain about getting the vaccine, because it's a good incentive. If you can see someone who is from the same group as you, whether it's over 70s or whoever it is, and then that's great. I mean, obviously the gold standard is having someone that who's had it, that you can ask questions about and say, how was the aftermath, and what side effects did you get, and so on. That's ideal. But until such time as everyone's got access to someone like that, then I think the media can certainly provide those kind of role models or in communications campaigns. Certainly a great idea.
Excellent. So, Sameer, we talked about anti-vaxxers, people who are hesitant, and people are just waiting for alternatives. Do you think we need to be thinking about the tail enders early in our communication strategies, or is this something that we are perhaps waiting to see how many people get on board early and then deal with the challenges of the ones that are hesitant, or perhaps can be made more enthusiastic with some clever communications and engagement?
Yeah, I think good point. I'll go back to the survey finding that both me and Doug highlighted on the 21% people who are resistant. And then I'm also looking at the numbers that are coming out from the medical authorities, who say that we need to have 70 to 85% people vaccinated to get the herd immunity. So I think that number is not very far off, 20% versus 85, when it's close, 15 to 20%. So taking on Doug's phrase of the holdout groups, perhaps those holdout groups would be that 15 to 20%ers. My point would be, I think that's the hardest one to convince. And we know from other behavior change contexts, it takes much more effort, money, time to convince the last 20%ers. So I would suggest, as a pragmatic approach, we should go for the 80%ers. Those who are, and I'm going to say, of those 80%ers, 20 are on board, and the remaining 60 are maybe in between, the middle group that Doug was talking about, who are open-minded. They are not completely closed. They just need the right information, the right evidence, as you said, actual stories of people who have taken the vaccination and are safe. They need convenience. So I would go after those 20 and 60%ers, and then hopefully, eventually, in its own sweet time, the last 20%ers will join the bandwagon.
Thank you very much. Well, being conscious of time, I think I will thank you so very much for entertaining all of these questions and giving us those insightful answers. And I'll hand back to you, Sameer, to close out our session today. Thank you.
Thank you very much. And thank you all audience members to participate and contribute to your comments and questions. I'm seeing the chat room is quite active right now. I do want just one more minute of your time and invite our engagement director, Dr. Timo Dietrich, to quickly highlight some of the forthcoming events that our center is organizing.
Thank you, Sameer. That was the one part I wanted to jump in. So yeah, we obviously run a number of different types of events every year. We have a range of free webinars, master classes, and upcoming change events this year. So we always encourage everyone to jump onto our events page. The link is blended into this slide here. You can see it here and check it out and register for as many events as you can, and certainly watch this space for our next change event, which we are currently curating and will have ready to be launched your way soon. And also a final note to jump onto our newsletter and sign up for our newsletter, as we will keep you informed about our free webinars, master classes, and upcoming change events so that you do not miss out. That's it from me, Sameer, so I'll hand back to you.
Thanks, Timo. And yeah, we just wanted to, again, close this session with thanking all of you for spending your 90 minutes of busy time. I hope you enjoyed and found our conversation, our presentations, all three speakers, the Q&A session to be informative, useful, thought-provoking, insightful. With those few words, I would like to close the session, and let's hope we meet somewhere virtually and hopefully in person. Thank you very much.